So good morning, good afternoon, good evening, everybody. This is a new NEMUS webinar, and it's going to be focused on achieving access to HIV pre-exposure prophylaxis among adolescents and youth in Latin America and the Caribbean. Why and how? You know, much can be said about this. What we can say now is that at present, efforts to incorporate HIV PrEP among available preventive options, especially for people at greater risk, are just starting to materialize worldwide. Such efforts for access to PrEP have been oriented primarily to the adult population, both for scientific reasons, because there are still some doubts about the generalizability of the effectiveness of PrEP in adolescents due to possible differences in adherence, or there were, and for legal reasons, requirements of a legal framework of each country for the participation of minors, particularly. So specific clinical trials in this population have shown that the effectiveness of PrEP is all right, and that it's increasingly clear that some young people are exposed to very high risks and should be able to access PrEP. So in our webinar, in our two webinars this week, one in English today and on Thursday the 30th in Spanish, we're going to focus on this topic. And it's going to be in charge, the presentation is going to be in charge of Alejandra Trocero. So Alejandra is the Regional Adolescent and HIV Specialist at the UNICEF Regional Office for Latin America and the Caribbean, leading the work on adolescent health, including access to PrEP in her organization. She has 20 years of experience working on HIV and sexual and reproductive health, and prior to joining UNICEF, she held positions at UNDP and the International Planned Parenthood Federation, focusing on HIV and sexual and reproductive health integration, establishing a 5-year research program in 3 sub-Saharan Africa countries to assess the efficacy and cost-benefit of integrating HIV and sexual and reproductive health services with Population Council and the London School of Hygiene and Tropical Medicine. Alejandra, who hails from Argentina, has a degree in psychology and a master's in science and reproductive and sexual health research from the London School of Hygiene and Tropical Medicine. So I will stop there. I will just say that this is it's a honor to have Alejandra here with us today. She will present for part of the hour. At the end, we'll have some time for questions and comments. This session is being recorded and it's going to be uploaded to our YouTube channel and our website, the NEMUS website. So welcome again, Alejandra, and the floor is yours. Now we're going to make you the presenter. Miguel is going to, so now you have the role of the presenter, so you can share your screen and operate your PowerPoint, okay?
Thank you very much, Carlos, and it's a real pleasure to be back in the NEMUS webinars. I think I was here about 2 years ago when we started to talk about PrEP for young people and what it means getting PrEP for adolescents. So the focus of my presentation is actually a reflection about where we are at and what it will need to happen in our region if we want to scale up PrEP or to actually deliver PrEP to adolescents. So I'm going to start by giving you a little bit of details on where we are with young people and adolescents in Latin America and the Caribbean, where the infections are taking place, what we know about it. And then what is happening in our region that probably many of you already know in terms of countries and scaling up of PrEP in our region. Some of the challenges when we think about delivering PrEP for adolescents, and some additional considerations for providing PrEP. And I want to have a sort of a reflection about what it means to deliver PrEP or to offer PrEP to adolescents and how we create or give demand to adolescents for PrEP. So this is the outline of the presentation. I'm going to start by showing in these two slides what is the situation in terms of new infections in Latin America. And I would say over the last 17 years, as you could see, for the, I'm particularly interested in the red line, the 15 to 19, and in overall the 10 to 24, which is the purple above the red, is that the level of new infections have not changed. We are not talking about big numbers, but we're talking about constant numbers. So I don't think we have done sufficient. Then we look at the line green on 20 to 24, there we start seeing some differences, but again, of the last 2 years, the numbers are stagnated. These are estimations that's coming from the UNAIDS data, so it's estimations that countries report, so it's not actual number of new infections. But when we look at the few countries that do have data on adolescents, we also see a sort of a similar picture. In some countries with an increase in new diagnosis among the 15 to 19. The second graph is about the distribution of new infections among key populations. I think we all know where the infections where new infections take place, or what groups are most affected. But again, I don't think we have done any analysis, or we don't have good data coming from our region to say exactly which are the groups that, in terms of adolescents, who are the adolescents at higher risk of HIV. I would say that for the 10 to 14, I think we have to be careful in terms of new infections, because what we see here is a bulge coming from vertical transmission. Just a point of just for information. We look at with PAHO, we look at late diagnosis in 0 to 14. And we see in some countries more than 40% of cases diagnosed on the 0 to 14 are late diagnosis. So there are adolescents who have been diagnosed during later in their life. I mean during the adolescence time, which probably had been infected through vertical transmission. So it's something for us to reflect as well in terms of where we are in the region. In terms of the distribution, 1/3 of new infections take place among young people, so it's 15 to 24. But when you look in some countries, that 3% is even more, is more than 50% in some countries. So this is to give you a little bit of a sense of what is the current distribution of new infections per age. And the next one is around distribution by sex. And here I think it's a very interesting picture, because when we look at adolescents and where new infections are happening, and by new infections I mean estimations and also diagnostics. So it doesn't mean that because we don't have incidence data, as you know, in this region. But I think the picture is quite interesting, because you see on the bottom a couple of countries where more than 60% of new infections, or even 50%, between 50 and 60%, are happening in young girls. So in terms of thinking about PrEP, while we understand, and the case is clear for key populations, and in particular for young MSM and young transgender women, I think the conversation around young women hasn't been placed in our region, and I don't think we need to think in all countries, but I do think that in some countries perhaps it's a conversation that needs to happen in terms of whether young girls should also be considered for PrEP. In terms of availability, there are currently 11 countries that are implementing pilot projects or demonstration projects, and I wanted to show first the countries that that I mentioned, and the map is showing the reporting of governments. So where national governments are reporting on the UNAIDS monitoring system. So there is still for many countries, these demonstration projects have not become part of their national programs. So only Bahamas, Barbados, and Brazil are providing PrEP through the public sector, and they do have developed protocols recently, but for adults. Brazil, as you probably know, there is a demonstration study happening for adolescents, looking in particularly at the adolescents population. As Carlos mentioned earlier, one of the biggest challenges when we think about delivering PrEP for adolescents are the legal barriers. So medical age of consent, also the age of consent for medical services, is in most of our countries in the region is 18 years old. So although some of the countries have made adjustment to get access to HIV testing for young people aged between 14 and 16, when we consider treatment, and for example Truvada as a case, the legal barriers are higher because it's a medical intervention, and therefore is going beyond the access to HIV testing, for example. And I was talking to some colleagues in Guatemala, for example, where they have a community-based clinic delivering PrEP and even doing HIV testing, and some of the barriers they have is if a young person below age 18 come to the clinic to solicit an HIV test, and they have the autonomy to ask for that service, then if that person is diagnosed HIV positive, they will need to request their parents' presence next time they attend a health service. So this is one of the biggest barriers that we have in our region, and in many of the regions. You see Eastern Europe as well, they have more than 90% of countries do have barriers for accessing health services. So this is something that we are looking at, particularly in terms of discussing with governments whether there are opportunities for reviewing some of these, the legal age of consent for access medical services. As Carlos also mentioned, we do have the evidence that PrEP can be delivered to adolescents. Most of the data that we have is coming from the north. So the Brazil demonstration project is going to be the first one from the south, from our region. And then the other region that is having a lot of movement right now, and we see very interesting innovative interventions, is in sub-Saharan Africa. A couple of considerations. So first, FDA approved the use of PrEP in adolescents in May this year. So from a safety perspective, it has already been approved by the FDA in the States. WHO has launched a module. I just put a picture there. You see the module that WHO had recently launched in last month. Is a module for delivering PrEP to adolescents. So we already have some guidelines. We do have, the science supporting that. But we have to now think about, okay, we have that level, but what happened with adolescents? And what is the life of adolescents? And whether the models that we have to deliver PrEP are actually capturing for the needs and lifestyles of adolescents. So I think one of the biggest challenges that we have is that adolescents' lives are complicated. And I think we have to acknowledge that it's a time in life that where lots of changes take place at a very different levels, psychological, cognitive, physical. So how to integrate an intervention in a lifestyle that is already quite complex. So this is something, I think this is one of the first big barrier in terms of adhering to treatment and maintaining certain continuity, a regularity in the uptake of treatment. The second one is around risk perceptions and about HIV. And some of the literature show that actually adolescents with higher risk are usually the ones that less likely will identify the need for PrEP. And these are small studies also conducting in the States. But then, give us a sense of whether young people really define risk and understand risk and understand the importance, for example, of using PrEP as a preventative method. Issues around negotiation, sexual negotiation skills, and I think you probably remember when you were a young person and risk was not something that we take into consideration. The world was in our hands and we wanted to explore everything. So in a way, we also have to think about, in terms of delivering services to young people, we also have to think about that particular moment in time, that moment in the lifetime, and what it means and what sort of strategies we use for that. And then the next point is around delivering a health service that is usually delivered through an HIV clinic to somebody who is that is HIV negative. So we have, on one hand, adolescents more likely not to attend a health service because they don't see the need to go to a health service, to attend health services. And then on the other hand, we have an intervention that could save life, that could prevent new infections, but the only people that could prescribe Truvada in most of our countries are medical doctors and usually are infectologists. So how we, in a way, bring these two worlds together, a group of young people who are not going to identify risk, who are not going to go to a health clinic, and on the other hand, a health system that is organized around HIV services. And for an HIV negative person, perhaps going to an HIV service is not something, considering the stigma that exists around HIV, probably is not a service that will be appealing to a young person. So this is some of the considerations in terms of the supply. And therefore, so how we ensure that PrEP is delivered and in a way that talks to young people. And what I'm putting here are some of the information that you could find, or I could find on the web. And I just wanted to mention the campaign, the Latin American campaign on Quiero PrEP, I Want PrEP. That the first things when you open that web page is a sign that saying, please note this information is for adults above 18 years old. So clearly mention that it's not the information is not for young people. So I think we need to think about what it means creating demands for adolescents, and whether is our role as adults, as health providers, as public health specialists, to define how that demand will take place, or we need to allow young people to design and define that demand so that it's owned by them. They became much more appealing and much more sexy for them. So it became something that is actually appealing, and it's something actually that they could see it will benefit them. And I'm not sure whether what we are doing for adults and the way in which the demand creation takes place in adults is the way that needs to go for adolescents. And I know in Brazil, they are already looking at alternatives and testing different models, whether it's online strategies, whether it's using clubs, using mobile units, peer-to-peer support. So what different alternatives and modalities should be considered to ensure that young people, and particularly adolescents, are accessing PrEP and have the support that they need. And lastly, PrEP is not just a pill. And I think it's important to recognize that PrEP is a program that includes ongoing support, they include regular health visits, they include a regimen and a structure that sometimes go against the lifestyles of young people, and is for us something to consider. So I'm going to stop here. I just wanted to acknowledge a number of people who had helped me to prepare this presentation. And I have to say that I did this presentation in Amsterdam at a panel on access to PrEP, and I think it's interesting to see the challenges that across the world we are facing. I think it's a proof intervention, but there are too many questions in terms of how we move into the implementation phase. So thank you, and welcome questions and a conversation about how we continue promoting PrEP in our region. Thank you.
Thank you, Alejandra. That was very nice. Now, I mean, it's still quite early, so we have, a lot of time for discussion. In fact, since we have time, we may not necessarily have to do it via chat. So if there are people who would like to, to make a comment using the microphone, people are welcome to do it. So, we could do it. You could let us know that you want to do that. Until we, maybe you can indicate via the chat that you want to make a comment. While we wait for that, I can say that it's a very challenging time, because in many places in the region, you may know that Alexandra, in many places in the region, the epidemic is becoming younger and younger. Peru is one of those places. I was also in Chile later last year, and they were actually interested in implementing PrEP, because among MSM, they had many more cases, which had made their epidemic younger. They were still essentially among young gay men. In Peru, we have had for many years an epidemic that was predominantly, at least in terms of means of transmission that people reported, predominantly heterosexual. Now, we are seeing a superimposed epidemic of very young people, particularly men. But since very young men are, not necessarily already identified as gay or anything like that, many of them are bisexual, have female sexual partners. So definitely we are observing an increase in the number of cases among men, young men, but also a relative increase in the number of cases among young females. And definitely there's some more cases of transmission at very young ages, between 15 and 19 among men. But as I said, it's difficult to say to what extent that is limited to men, or that is also reaching young women. So I guess we are observing a change. Probably one first comment is about the changing landscape in sexual risks among young people. I don't know if you would like to say anything about that, because in my impression, probably in relation to the changing technology, to mobile technology, the new apps, new ways of reaching people, new ways of contacting people for social issues as well. Much more information through the internet. Probably the sexuality in our culture is changing, and probably acceptability of contacts through the internet and all that. So definitely we are looking at transformations in the epidemic that we hadn't seen in many, many years, and that is probably having an effect on the epidemic. So would you like to comment on that? Alejandra?
Obviously, those are questions that are, yes, could you hear me now?
Yes.
Hello? Can
Yes.
you hear me?
Yes.
Okay. Yes. Yeah, some of your comments and questions are some questions that are going through, you know, the discussions that we are having internally as well, in terms of, first of all, we know that the rate of new infections are taking place between the age 15 or 19. Unfortunately, we don't have good data from national governments, but a few governments that do have good data and is starting to look, for example, at age of, CD4 counts and viral load at time of diagnosis. That usually happens after they are above 20 years, and we have to think about the legal barriers and why lots of young people decide to get tested later in their youth rather than when they're young, because there are some legal implications on that. But when they look at a CD4 count and viral load, clearly the onset of infection have happened probably 5 or more years earlier. So we don't have good data from the whole region, but in countries, some of the countries are starting to see and realizing that actually the new infections are taking place among very young people. And as you say, the issue around sexual identity, sexual orientation is quite fluid in the new generations, and much more than I would say now in terms of the fluidity of sexual relations, and therefore is something that we need to think about as well. I think my sense is that this new generation of young people are challenging the ways that we perceive gender norms and gender roles, and challenging our perception of gender roles. So perhaps something to do there. In terms of reaching out to young people, I will say is digital, because is the way in which the world functions right now. And I do think there are a number. I mean, we did a landscape analysis this year around online services to try to figure out, to see what information exists online in terms of sexuality, in terms of HIV, in terms of services, to see whether adolescents are accessing information that is correct, appropriate for the age, through internet. And unfortunately, we didn't find much. So a space that should be full of good information, because we know that adolescents go there to get information, is almost empty in this region. It's very, very few groups that are really targeting the online domain with proper information in a way that speaks to young people. So this is something that we would like to explore a bit more next year, to go more in depth in terms of the few examples that we identify, to see what is provided. Which brings me to the next question that we are talking this morning about PrEP, which is just one element of a much bigger package of comprehensive or combination prevention. But are we clear on what is the package of prevention for adolescents, for young people? Are we clear that whether what we are promoting today is the all campaign, but we haven't, but perhaps we haven't refreshed and engage with young people again to say, well, what they would like to see online, what sort of information, how to provide information that is appealing to them. They're not reading, they're reading just few characters. How we ensure that the information is clearly, getting into their into their interests, using their language. And I think this is a big gap. I would also say that something that we are exploring in other domains, but I think is something that we should think about for HIV, is the use of artificial intelligence, and using, for example, Facebook platform to be able to provide a safe platform for people to interact, and even using artificial intelligence to create characters to interact. So there are histories that could go around and where young people could play to better understand their risk and what they could what they could do when a risky situation takes place. So I think there are many opportunities, and I don't think we haven't really tackled this wide universe of options for promoting HIV prevention for young people.
But I think Jill wanted to participate, so I think you are unmuted. Would you like to intervene, Jill? I think your phone is still unmuted.
Okay. Yes. Can you hear me?
Yes, we can.
Okay. So I had, hi, Ali. I had actually three different questions.
Hi, Jill.
Hi, it's great to hear you. And thanks for the important work you're doing. So I was struck by the lower rates of HIV among sex workers as compared to their clients. And I would like you to discuss that. I know that's, and if we know any of the ages of the sex, those who are in sex work, the sexual identities of those and their clients. And then I guess the second question is, are there any sex education programs in Latin America which discuss gender and sexual identities? And then my last question is, what do you think is the best way to move forward in terms of increasing access for adolescents? And do you see any countries or any movimiento to go in the appropriate directions in terms of, outside of HIV services, youth-friendly, all the things we know that work with adolescents? Those are the end of my questions.
From the end. Thank you. Thank you, Jill. I'm gonna start from the end, and perhaps I'm gonna ask also Carlos to talk a little bit about sex work, because I have my reading on that, but perhaps there are other people that have other readings around the sex work epidemic. In terms of services for young people, I think what we see in this region is a very verticalized response to HIV. As we could also say that it's a verticalized response to pregnancy, and it's a verticalized response to other health problems affecting young people. So I would say one of the challenges we have, I think lots of the countries do have youth-friendly services. I don't think those youth-friendly services has a package that really talks to young people, and that's my concern. In terms of young people most affected by HIV, I think there are a lot of many countries. I think we did an analysis, particularly in Spanish-speaking countries, of the number of countries that have a national program, a national health programs for adolescents. So it's whether it is a national health, adolescent health strategy, or operational plan, or a part of their overall national health plans. And I will say fairly more than 70% of countries do have some level of a component on adolescents' health. Do adolescents' health providers, the structures that exist at country level, talk to with HIV? I would say no, are very limited. That conversation takes place because the HIV had been established historically through a tertiary infectious disease sort of intervention. So we have very many parallel structures in place, but I don't think they have come together. There are a few very interesting attempts. For example, I would say Jamaica is a good example where and it was a huge outcry, and you probably know this, Jill, but they decided to combine all the health interventions related to HIV under the family health board. So everything that has to do with adolescent health is now part of a one program, and has its pros and cons. But what is clearly is that created a sense that things that the movement have to be towards integration. As you know, I've been working on HIV/SRH integration for many years, and the movement I saw in other parts of the world, I haven't seen it in Latin America for many different reasons. So I don't think we have advanced that agenda. And I think this is something that we should think, and when I was talking about a package for adolescents, an HIV prevention package, that is what I'm referring to. Where is the lever? In what places is the lever? So if it's delivered in the healthcare, what sort of a package we need in the health system? If it's delivered through school-based approaches, and again, the sort of health education that exists in a school is very, very limited to whatever the teachers are able to deliver. And I think we have to recognize as well that the integration of schools with health is also very limited and very much reactive to whatever problems exist in that community. And I think we recently have seen very interesting movements around mental health and the delivery of mental health services within schools, but we haven't created that same movement or haven't seen the same movement when we talk about sexuality and issues related to sexual health. In terms of the curriculums, and linking to your other question about curriculums in Latin America, I think we have, I would say, 3 or 4 different realities in this region, with countries that have good policies having good comprehensive sexuality education, like is the case in my country, where you have a legal framework that allow for that conversation to take place. Therefore, the programs around comprehensive sexuality education respond to that legal framework. As the legal framework became more restricted, is also more restricted the ability of integrating certain difficult topics or more sensitive topics into the curriculum.
Okay.
This is in a nutshell, yes.
Okay, Alejandra.
Go ahead, Carlos.
No, Daniela Henry has a question, so or comment. Could you go ahead, Daniela, please? Danelda, sorry. Danelda. Are you there, Danelda? You can speak. Your mic is open. She had asked to speak, but I don't know, maybe she's not there. Danelda, are you there? Okay. While we wait for her, I can. Yeah, I guess it's very interesting, but it's making me think that we're discussing access to PrEP, and there's so many other issues that supposedly would come before PrEP. We're talking about access to essential services, access to very basic things that are not accessible, and yet we are already talking about PrEP. And of course, we're not talking about PrEP for everybody. We're recognizing that there are some young people who are at very high risk, and probably one important point is how to identify and offer PrEP to them. No? So I don't know if you would like to comment on this, and Danelda or Elena, I don't know, you both have your mics open. If any of you wants to participate, please let me know through the chat. Go ahead, Alejandra.
Yeah, it's a very challenging time, because I do think that PrEP is a great opportunity for having a conversation around risks and around sexual behavior and around autonomy and agency to make decisions, which is part of what is when we talk about adolescents' health, is the things that we talk about. So PrEP is a good entry point, and as you say, it's not for everyone. It shouldn't be for everyone, and it's not forever. It's just for moments. And I think some of the fundings from from Sub-Saharan Africa, particularly from South Africa, some of the work that is happening around accessing PrEP for young girls is showing that actually the perception of risk change over time, and therefore PrEP is a really interesting intervention to also look at what happened in terms of risk and how risks evolve and change over the lifetime, and even from month to month in the lives of adolescents. So I do think that in the context of Latin America and the Caribbean, and considering where the epidemic is taking place, obviously young MSM are the ones that should be, they should be prioritized, as well as young transgender women, because I think it's from where the epidemic goes. But in countries like Haiti or Guyana, where we see that actually the percentage of young girls, new infected young girls are quite high, are more than boys, is whether we have to also think about interventions to address, to target young girls. And I would say this is a very specific and context specific. But I do think that the most, for me, the most valuable point around promoting PrEP is around that conversation, open up that conversation about risk, and providing tools to young people to be able to assess their own risk. And I think it's something for some of us have been working on HIV for many, many years. I remember 20 years ago, we were talking about, modes of transmission and risk. And I remember, creating a sort of a table in some workshops and say, well, what is most risky? What sort of sexual activities are more risky than others? Today we have PrEP. So that conversation, in a way, PrEP will give us the entry point to continue with that conversation and strengthen that conversation. I'm not sure if that goes into the direction of your comment, Carlos.
Yeah, definitely. As you say, it's a challenging, and a complex time to interpret. There are signs of progress and at the same time signs of, difficulties that seem to have been resolved before. Now, if it may be an issue with providing PrEP to adolescents in general, or to adolescents for the sake of prevention of sexual transmission in contexts of difficulty. For example, in terms of PEP and rape, do you think it's rape or sexual abuse? Do you have any data? And I'm talking about post-exposure prophylaxis for young people who have been raped or who report sexual abuse. Are there any data in that sense, Alejandra?
The only data that I know is from Brazil, because at some point and supporting, looking at the PrEP project that is now implemented by Untitled. I was interested to look at post-exposure prophylaxis to understand what is the current trends and uptake. I don't think many countries report the reasons for using PEP on a regular basis. Therefore, it's not clear whether it's used because of sexual abuse. Even on the Brazil statistics, I was looking, for example, there is a high proportion of uptake of PrEP of PEP takes place on young people between the age of 10 to 19, and when we look at the female-male rate, most of the PEP that happens on the 10 to 15 are girls, which make me think that it's part of the protocol for sexual abuse. Then the other segment that use PrEP is the 15 to 24, which are mainly males and related to the use of PrEP for sexual risk, sexual exposure. So, but I don't think from the routine data that exists, we were able to say whether PrEP is being used systematically for preventing HIV transmission after rape or sexual abuse. I don't think we have good data on that. It's something that I would like to look at in more detail, and is actually pending. I've been exploring a little bit with UNAIDS to see whether we could get that data, and it's not that simple. But I think it's something pending that we should look in more detail.
Mm-hmm. I see that Rosalind Coleman is with us in the group. I don't know if she would like to make any comment on this topic. I mean, from UNAIDS. Anyway, hello, Rosalind. While we, I mean, I don't know if she's listening to us right now, but definitely you're right in terms of young men being, I mean, at the pattern that you described, young women from 10 to 15 or 18, I mean, being given PEP probably correlates with sexual abuse or rape, or while young men between 18 and 24 correlates with requesting PEP for sexual exposure. Definitely, in many places or countries in the region, PEP is available in theory, but in practice, in very few countries, I mean, that availability is effective for people in services. In Peru, for example, it's in theory it's available, but I mean, for that, I mean, the regulation says it's available, but in practice, people don't ask for it. The service is not talked about. I mean, it's not described, and providers don't plan for, to offer it. No, and I mentioned PEP in relation to PrEP because in many places, and even in our ongoing study in PrEP, we consider, at least it's considered in Brazil, that people who use PrEP or PEP are candidates for getting into PrEP when they complete their month of treatment, their PEP month, because obviously they may be in a situation like that again. So I think we should stop thinking of those services and options as isolated, and consider combination HIV prevention, consider the importance of I mean, sex education, new ways of reaching young people, and the very difficult and still unresolved issue of how to improve access to health services, no? Which is something we still, in many places, haven't resolved. So I don't know. Again, any other, I mean, intervention from, I'm seeing, I don't know, Rosalind or Elena, I don't know who is Elena or Danelda, because Danelda had expressed she wanted to intervene, but I don't know, she's not responding now. Would you like to make any other comment about this, Alexandra?
No, I want to thank you for the invitation, and I think this is a conversation that we need to have at a regional level more regularly in terms of checking out what we are doing in terms of HIV prevention for adolescents, and PrEP, as you say, as part of a much bigger package of combination prevention. And I do think we need to revitalize that conversation, and I think it's the time now to start talking much more, and perhaps creating these forums of discussions on a regular basis, so that we could, you know, revitalize our prevention efforts in the region, which I think is needed.
I couldn't agree with you more, because I think, unfortunately, that I mean, it's clear that there has been a very strong movement towards implementing PrEP in many places of the world. I mean, the last HIV conference in Amsterdam was an example of how it became. I mean, it was a PrEP conference in many ways, but unfortunately, I didn't see. A real consideration of PrEP as part of one, as a national strategy that is part of a coherent combination HIV prevention strategy, no? And so that becomes a problem because we end up sort of single focusing on just one strategy that is intended for specific groups. It's not intended to be adopted by everybody, and in the end, that also creates problems because we will move from one incomplete sort of to another one that is also incomplete, no? And so I guess we need to, I mean, that implies sort of focus, implies a good plan and guidance so that we avoid getting into that trap and keep sort of the logic of the system.
Yeah.
Yeah. Anyway, so I think we have had a good discussion and many questions, and I really appreciate your participation, Alejandra. And so we started with this discussion in English, and we'll have our discussion in Spanish on Thursday, the 30th, at the same time. So again, this is going to be uploaded, and thank you very much. It's been very nice, and we hope to have an equally useful conversation on Thursday. Okay?
Thank you. Thank you very much.
Thank you very much. Bye-bye. We'll keep seeing each other. Bye. Thank you.
Bye.